So I think we'll give it one more minute to give people the chance to come in.
The chances.
Okay, it's 3 minutes past 5 now. Good evening, everybody, and welcome to this webinar, EANS webinar of the EANS Spine section, which is our 6th webinar now, and we recently switched to having these monthly webinars, though there are more to come. Now, today, I'm very happy to have as a guest and as a presenter for today's webinar, Bertrand Debono here. And the topic he's going to talk on is enhanced recovery after spine surgery, which is a topic which gained a lot of interest in recent years and was installed in some departments. So Bertrand, he's obviously French. He made his residency in neurosurgery in Rouen. Then initially had an interest in functional and stereotactic neurosurgery before he turned, then after residency, his interest more towards spine surgery, was for a long time working in Toulouse from 2006 to 2020. And now he came back to Paris, working in Paris in a spine center in Versailles. He has an interest in enhanced recovery after spine surgery, and I would say you're one of the early adopters, or maybe you could call you a pioneer, as you just recently authored one of the big systematic reviews, or a big review paper about all the parts of enhanced recovery after spine surgery, which means the preoperative, intraoperative, and postoperative aspects, what it means. And I'm very happy to have you here tonight, giving you an overview presentation on what's possible with enhanced recovery after spine surgery. Thank you, Bertrand.
Thank you, Florian, and good evening, everybody. And it's my pleasure to be here, of course, on the invitation of the EANS. I'm very proud to be part of this session. And my second pleasure is to have Florian Engel as a moderator, an old friend. So today we won't speak about specific techniques, surgical techniques, navigation, or tubular retractor, or anterior or lateral or combined approach. It's more, you will see, and maybe if you are not familiar with the ERAS concept, that it's more philosophical or organizational reflection of the patient journey and of the organization of the care. It's not only a topic dedicated to surgeon, and it will be a very important point of my contribution to explain to you that ERAS is a holistic and multidisciplinary procedure. So I share my screen, not my screen. Okay, and I will try to make an overview of the ERAS for spine surgery, from theoretical concepts to guidelines implementation. So you are maybe familiar with such acronyms or such expression like this: fast track surgery, accelerated recovery, rapid recovery, and the last but not least, enhanced recovery after surgery, and the known acronym of ERAS. The concept was crystallized by Henrik Hellet, a general surgeon from Denmark, and more than 20 years ago, he made a lot of publication, and he started buzz with the ERAS at the beginning from the general and colonic surgery, and now this concept spread to all subfield of surgeries. Hellet stated that he made the hypothesis that the combination of unimodal, evidence-based care intervention to enhance recovery will decrease the need of hospitalization, convalescence, and morbidity. And it was the main important concept of ERAS. A lot of elementary steps from the beginning, pre-op, per-op, and post-op period of the journey of the patient through surgery to EANS, and all these modification of the steps are done in relation with the best evidence-based level of evidence-based in the literature. And the second very important point is that the fast-track surgery, or ERAS, has not been developed to reduce the length of stay, but rather to provide the pain and risk-free surgeries. And at the end, with this optimization of the patient management, the length of stay decrease. It's an obvious marker of the efficiency of your switch to ERAS, but it's not the principal goal. And the ERAS, the main goal of the ERAS is not to make some money, some medical economical improvement of your care, but of course improve the patient experience. But at the end, the length of stay decrease, and at the end, maybe you can spare some money, you or your institution. So that's why I don't like this kind of fast-track surgery, accelerated recovery, rapid recovery, all in relation with the speed. Much more interesting is the concept of EANS recovery after surgery. That's why the acronym of ERAS is now universally adopted by all the team concerned with this problem, with this concept. So the first steps, if you want to switch to ERAS in your institution, is to declare death to all the dogma we received when we were resident, when we were a medical student, and today, the dogmas of our teams, of our bosses, of our mentors, and maybe of ourselves, because as surgeons, we are a lot of a part of us are conservative. And that's some example of dogmas we heard 1,000 times, and I select some of them, but maybe you can do your own list. I don't know, fasting since midnight. I always train. I always brace my patients. I use systematic morphine, and so on, so on, so on, so. And this kind of little habits, this kind of used to, are to list and then try to confront with the experience, with the literature, and then maybe to suppress, maybe to improve, to create all the protocols with all the stakeholders, not only the surgeon. I spoke about drains. It's a wonderful example, but you can find such example for the physio, for the nurses, for the director, and everybody have to change the habits to improve the patient experience and to suppress all the things we're doing since centuries without having a real efficiency of them. 7 pillars of the ERAS and not 7 pillars of the wisdom. The first one is the patient education. It's a very important topic if you want to move to ERAS. The patient has to be educated before the hospitalization, and I will have some slide about it afterwards. The second part is to create protocols and to create a clinical pathway of the patient, to make all the stakeholders around the table, and it takes time because it's not only a meeting, it's a lot of meetings to decide. For example, in my institution, we are 7 surgeons and we are 7 ways to put a drain after surgery. I never drain. Some of my colleagues always drain 2 days, 1 day, suction drain, not suction drains. And it's very important to create an homogenic management and then to provide to the nurses protocols, lean and homogeneous, and it's not the easier part of the switch. The third point, very important, it's I spoke about patient education, but you have to educate the caregivers, and because it's a multidisciplinary approach, and you will see at the end of this presentation that as finally the surgeon part is the smallest. Of course, we have to dedicate a lot of time to address the control of the stress and the pain management, avoiding opioids, of course. We have to have a deep reflection concerning early realimentation, fasting, and early mobilization. That's physio, the same day, and even a few minutes or hours after surgery, and create secure discharge by system, for example, by score. The score is one of an examples. And of course, evaluate yourself, create data and optimize with the ongoing implementation period to improve yourself and your team. Of course, you can add on these 7 pillars little extra. Use MIS techniques. I will have one or two slides just to demonstrate to you that MIS and ERAS have a very similar rationale. We use the adapted fasting and to avoid physiologic stress of the patient until 2 hours before surgery. In my institution, there is a standing patient, but it's very frequent now. Patients walking themselves with their files under the arm to the block and not on a wheeling bed to avoid to be stuck on a disease position. The patients are advised to wear their own clothes to avoid to have the blue paper pajamas and some people call that pajama paralysis. And we use eHealth mobile application to create a link with the patient before and after the hospitalization. I will show you some example, and all those little details are to create a fluid, a smooth pathway for the patient before, during, and after the surgery, and before, during, and after the hospitalization. And of course, last but not least, forget traditions I'm used to do, because it's and maybe it's one of the most important parts of this talk. You will find a lot of paper if you type ERAS on PubMed. This is a very important paper of Ole Ljungqvist, one of the members of the board of the ERAS Society, because there is an ERAS Society. And you will see in the majority of the papers concerning ERAS, this kind of chart with the different period I already mentioned. For example, before the pre-admission, you will see that it's very important for the patient information, and in this institution, and in my institution too, this is dedicated to nurses. Intraoperative, minimal invasive surgery, minimized drains and tubes, and post-operative, multimodal opioid sparing, pain control. It's more or less all the pillar of the ERAS, and you will find in every paper of the ERAS those kind of recipes with each steps and the stakeholder of the corresponding steps. And from 20 years, it was a lot of papers concerning all subfilar surgery, general surgery, cardiothoracic surgery, gynecology, orthopedic. And I will give you only 2 examples because it's a lot, but just to see you how a simple change of organization of the team can provide good results. For example, in this patient, in this study, meta-analysis of RCT concerning ERAS in colorectal surgery, they demonstrated that the complication risk was divided by 2 just by changing the habits and the organization. And I don't know an implant or a perioperative imaging system or a wonderful discal prosthesis can provide this kind of result. And they divided the risk of complication by 2 just to change the organizational management of the patient. An example in orthopedics for hip and knee arthroplasty, and they reduced the mortality at 2 years by minus 30%, just changing the organization. And once again, I don't know any arthroplasty system implants can give this kind of result. And that's why ERAS had a lot of success in each surgery, and recently paper concerning ERAS and spine spread from the team, from the researcher, and you can know if you type ERAS and spine in PubMed, you will have a lot of interesting results. And this kind of 2 curve, the traditional curve and the curve of ERAS, those curves describe the aggregation from the surgery, the physiologic aggregation, and these 2 different curves are symbolic to the ERAS, and now it's the logo of the ERAS Society. But once again, it's very important to understand one of the important points. The length, the shortening of the length of stay is not the principal goal. It's just a consequence of the improvement of your organization. And the first result is the improvement of the patient experience. And at the end, the length of stay decreases. So there is an ERAS society, and you can see here the two curves, which is now the logo. The two last meetings were cancelled and postponed, like in a lot of scientific society. The next ERAS society will be in Madrid in the beginning of June, and it's the first time in 8 Congress that there is a small session dedicated to spine, and I will present some results of our recently published guidelines. So there is a rationale to apply ERAS to spinal procedure. The first is the trend and the volume of the spine surgery. There is this is a well-known paper of the well-known researcher Deyo, and it's already old. It's more than 15 years ago, but I'm sure that this kind of curve showing an increasing of the spinal procedure have not changed since 15 years, and they compare the lumbar fusion with hip replacement and the knee arthroplasty and the increase in volume. You can compare increase in volume in a period of 5 years in the United States between at the beginning of our centuries. It was 13%, 15%, and more than 100% for lumbar fusion for degenerative conditions. There is a lot of patients. It's a lot of money. It's a lot of organization. So it's the first point of interest to develop this kind of innovative procedure. The second is that we all know that we address risky procedures. First of all, because the spine, of course, it's not a problem today to make anatomy, but it's in a relation, anatomic relation with spinal cord and nerves. And when there is a complication, it can be devastating for the patient. And even if there is no neurologic sequelae, it can be functional with a burden of socio-professional disease. And we all know this. And even if the procedure is well done, there is sometimes deceitful result for the patient and for the surgeon. And it's always good to adopt the protocols who can improve the result and decrease the risk of complication, because it's the case in all the subspecialty who had already adopted ERAS. Another element of the rationale is the great variability of length of stay that demonstrated for a same degenerative procedure, for example, according the team, according the surgeon, according the countries, and ERAS provide. Of course, it's not the. I said a lot of time that it was not the main goal, but it's very interesting to have a tool to make more homogenic this very variable length of stay. Another point very important is the pain. This is absolutely wonderful paper published 3 years ago, studying, analyzing all the pain of 180 different procedures in all surgery, and in the 10 first more painful surgeries, overall there is 3 spinal fusion and complex fusion surgery. And we all know that spinal surgery is painful for the patient, and the deep reflection that ERAS imposed to all the stakeholders taking care of those patients is a very interesting point concerning the pain. Another point, of course, is the metabolic demands and the surgical stress response for the patient. We all know that, for example, there is hundreds of examples that, for example, a preoperative nutritional status and albuminemia is an independent factor of complication and 1 month readmission after elective spine surgery. So this patient evaluation pre-op and when we address all these problems, it improves the result and it decreases the complication and the length of stay. So once again, there are some examples that all the topics you have to address for the ERAS. The first paper in the literature concerning ERAS was published a few years ago in Germany, and it is written in German. That's for you, Florian, by Pfleger. It was a team of Frankfurt, and they dedicate this paper on the patient education. It was more or less for spondylolisthesis, and with patient education, they decreased the length of stay of 4 days. And for the up to now the first paper published concerning ERAS and spine. But and the very important paper was published 5 years ago by Tom and White, a friend of mine. He was working in the UK, and he published like a big monography of ERAS and application to complex spine surgery. And like you see, you have always the different steps of the patient pathway with sub steps and stakeholders in relation with this. It's like a recipe for you if you want to adapt ERAS. It was the first paper crystallizing ERAS and spine. And the first clinical studies arrived very quickly, and the first to propose very interesting studies concerning ERAS was Mike Wang from Florida, and he published his approach to TLIF under local anesthesia and with a length of stay of less than 2 days. And with very good result in terms of complication and patient satisfaction. And the following year, the same team and the same Mike Wang published another paper more dedicated to medical economical advantages of ERAS. But at the end of the paper, he provided a very good summary of recommendation concerning the topics. And it's more or less what we have done more recently with the recommendation I will present to you afterwards. And we published our experience from Toulouse in different reviews, and but you will always have this kind of chart when you decide to operate your patient in my institution the same day. You can, as a surgeon, you can meet the patient 1, 2 more time. When you decide to operate the patient and you choose the date, the slot for the surgery, the patient meets the same day a dedicated nurse who makes a debriefing of all the stuff to the patient, because the patient receive a lot of information and a lot of information are lost. So the nurse go back to the prescription, to the organization, to the organization of the clinic, and explain to the patient the very important steps. And then the nurse this same very day present the patient to the physio team who made the patient a little education. And the patient receive a QR code for a mobile application, but you can use a laptop or a simple classical telephone if you don't phone if you don't want to use a smartphone. But it creates already a link with him with some important information in terms of education, but in terms you can register them the day before, like we register for a flight in the airport. All the patients arriving the same day of the surgery. No patient arrive the day before. There is walking patient through the OR, through the clinic to the OR. We try to avoid drains. We try to remove the cath and the urinary cath very quick, and to avoid urinary cath. And the patient, we try to avoid opioids, or to shorten the period where the patient receives opioids, and the patient is mobilized a few hours after surgery, and he leaves as soon as possible ambulatory for some procedure. Because for me, just a parenthesis, but for me, ambulatory is absolutely the same of ERAS. Ambulatory procedure are just the tip of the ERAS, but it's the same organization, the same concept. And when the patient leaves, he keep a link with the nurses through the mobile application, but there is no need to have a smartphone to be an ERAS patient. You can just have a phone call, but it's nice to create a link that you can sweep the visual pain scale. You can send picture from the scar. It's not a lot of application of this are already functioning worldwide. So it's more or less the scheme of our organization in my institution. It's this kind. I published 3 years ago our result concerning 3 different procedure: ALIF, ACDF, and posterior fusion. It was short fusion. Here in red, you have the national average length of stay in France, and in blue, it was in my institution before ERAS. In gray, after ERAS, you see we divided by 2 the length of stay for ALIF. We decreased a lot by 2 days for cervical surgeries, and it was the same kind of result for posterior fusion. And but our beginning in our pre-ERAS period was already in the good average comparing with the French global result. We didn't add difference in complication. We experienced less hematoma. It was significant but after the ERAS, adopting ERAS, and the satisfaction of the patient was very good. So it's a no. You will find a lot of application concerning ERAS, and not only for posterior fusion and for disc herniation. It was this in the beginning, but now every subfield of our the spine surgeries, for the idiopathic deformation, pediatrics oncology, and every level, cervical, thoracic, every age, elderly, young people are concerned by ERAS. And just some word about MIS, because I think that the rationale of the MIS and the rationale of ERAS are exactly the same. We published something with the Geneva team 2 years ago in our surgical focus, and if you are familiar with the MIS, you know that the main goal of the MIS is less blood loss, better pain control, earlier rehab, and shorter hospitalization. And exactly the same rationale of ERAS. So it's today there is no convincing high-level proof that MIS should be used absolutely for ERAS. And in my opinion, ERAS is not a question of MIS retractor of cannulated screw, but it's a more organizational topic. But the proximity of the two concepts is interesting. And in the literature, you will find a lot of. This is one of our work concerning cervical level in European Spine Journal published last year, and now there are convincing paper in very high level review concerning deformity, adult deformity, with good result and very significant decrease of 3 months readmission rate of patients in the ERAS group comparing with the pre-ERAS group in this paper in neurosurgery concerning thoracolumbar fusion for adult deformity. And from deformity of adults, it's now a target of ERAS for adolescent orthopedic scoliosis with the same of results, decrease of the complication, patient satisfaction, and decrease of the length of stay. For example, this is a free paper of the team of the Children's Hospital of Philadelphia, and you can download it if you want. And they explain their journey to ERAS for idiopathic scoliosis. They demonstrated that the length of stay can be reduced to 3 to 4 days, and it's very important for those young patients. And they give you this chart with a lot of advices, and it's free to download. So as you see, adult deformation, idiopathic and pediatric deformation, oncology, cervical surgery, anterior, posterior, ERAS is not, it's a holistic concept. Because we all know that successful surgery is not only a correct indication and your perfect technique. Of course, there is a part of the patient, but there is a lot of factors, and all we can do to improve the results and to decrease this kind of unknown factor is a very important thing to standardize our protocols, improve our results, and homogenize our practices. So it's not so easy to implant ERAS in your own institution. I was lucky 10 years ago because we were owned in my private hospital by a Swedish health group, Capio. No, it's part of Ramsay, but they were absolutely convinced that ERAS was a good thing, of course, for medical economical reason, but for the patient too. And they was very pushy. And I must admit that at the beginning, the surgeon and all the caregivers was very reluctant. And it was the administration who pushed us to adopt this kind of protocols. And at the beginning, I was cautious, but now I'm absolutely convinced, of course. Of course, once again, ERAS is holistic, and if it will never possible if you are convinced by my talk or by the paper you have already read, that it will be impossible for you as a surgeon, even if you are very energetic, to switch to ERAS alone. It's very important that if you have a strong incentive from the institution, if there is a corporate culture of care improvement, and not only for economical reason. it's very important because you have to request all the stakeholders. You have to organize a lot of meetings with the managers, the caregivers, the nurses, the physio, the anesthesiologist, the surgeon, and so on. So you have to harmonize the practices and the protocols. I spoke about this already. And you have to have the feedback of the patient. And even if you are lucky and it's a good time for you, it's possible to have a reflection of the architectural modification you can do in your institution to improve the patient pathway. Of course, it's not the most important thing, but in the new hospital, there is a reflection of the architects on this new way to organize the patient experience. So go back to the ERAS Society. The ERAS Society, the goal of this scientific society is to organize guidelines or recommendation for all the subfield of surgeries. You can find the guidelines. Most of the time it's published in open access journals, so you can download it depending on your specialty. I was lucky and proud and honored to coordinate the first recommendation concerning lumbar spinal fusion. It was published last year in the Spine Journal. It's a big baby. It's a 7,000 word paper, and we have a lot of it's a review, of course, and we tried to mix surgeons, anesthesiologists, physio, nurses, of course, methodologists, to provide the high level of proof concerning ERAS. But we all know that it's a frequent discussion between Florian and I, that specialty there is a lack of high level publication of high level evidence. But you all know that for recommendation, it's possible to make a strong recommendation even with a low level evidence. So we were those stakeholders, and I won't detail all my paper because it's in open access in the Spine Journal. You will be able to download it if you want. But we define 23 topics with the pre, intra, and post-operative period, and just we use, of course, the best level of evidence at our disposal, but we all know that the level of evidence in spine surgery is very heterogeneous. And this reflection reflects in a lot of topics who have a very low level of evidence, but the recommendation grade can be strong. For example, we spoke about MIS techniques in a lot of other specialties guidelines. There is an incentive to use MIS techniques with a lot of evidence. In spine surgery, there is no level of evidence that you have to use a tubular retractor or MIS techniques, but of course, due to the very to do the same rationale, the recommendation that is strong. It's an example from all this. So if you consider this 23, just I want to show you, and once again, I go back to the very low part of the surgeon concerning the ERAS, even if we are all neurosurgeons. This is the only topics dedicated to surgical access, management of drain, and urinary drainage that we share with the anesthesiologist. But all the other topics are multidisciplinary or dedicated to nurses or to physio. Of course, it's your patient, but you see that ERAS is not a surgical topic, but an holistic one. Of course, evidence-based medicine is not only the paper, and the paper don't govern our lives. We have to meet it with our own experience, the will of the patient and the family of the patient, and of course the best evidence at our disposal of the expert advices. And you can even do a lot of interesting statistics. Sometimes it's not in connection with the reality, but once again, we try to propose to you what's the upper level of evidence, and then you have to try to implant it in your own institution. Florian spoke about early adopters, and it depends on where you can, if you are very conservative or laggard, or like in the majority. No, I think we are in this part for the spine surgery, and and it will be probably my conclusion in a few slides. I'm sure that in a few years we won't anymore speak about ERAS. ERAS will just the way to do surgery, and for now it can be innovative to give a patient an application on the mobile phone, or to use modern fasting, or to avoid to use opioids. But in 2 years, everybody will do this, and I will never speak about ERAS, and I will speak to other topics. I hope it will be the only way to do surgery. So to get started, of course, once again, it's a real incentive from the establishment and or for the management. Once again, I insist on the multidisciplinary management. You have to create your protocols. It's good to have a leader, not obviously a surgeon, but a chief nurse or physician, depends, but somebody who can motivate all the stakeholders. Referees in each group of nurses, surgeon, anesthesiologist, to be present at the meeting, and to try to create the aggregation of all the feedback of all the teams, and of course involve patient at one level of the evolution of your progress. We go quickly on this. In my institution, for example, there are dedicated nurses. They are on call H24. And they create a real link with the patient. They brief the patient before the surgery, and when the patient is back home, they are on call. They can they receive the signal of the patient from the mobile application. There are 3 kinds of alert: red alert, yellow alert, green alert. And they call back the surgeon, or they call back the patient most of the time, just to optimize the painkillers. But it's very important that the shortening of the length of stay don't bother, don't stress the patient, and don't impact the GP or the emergency service. So we keep a link with the patient, even if the hospitalization is short. I published this in European Spine Journal a few years ago. Now we change our mobile app. There is a lot of app. Maybe you already used this in your hospital, and it's very. To be honest, at the beginning, before I believed it was just a gadget. But now I think it's a very interesting tool, and it's proven by the survey we have done among our patients. So once again, I go back to this kind of chart. I think there's 2 papers are symbolic. The first, on the left, it's an editorial of the boss, the president of the Anesthesiology Society in the UK. And it was a special issue of the British Journal of Anesthesiology, published a few years ago. And the whole editorial of the president doesn't even mention the name of surgery or surgeon. It's not a question of ego. But in the next issue of the same review, British Journal of Anesthesiology, it was a response from Henry Kellett. He responds with a bazooka and a southern paper on first-class journal, and he underlined that the ERAS was a multidisciplinary technique, and it was very important to incorporate all the stakeholders in a multidisciplinary effort to achieve optimal outcomes. And I think it's symbolic because you will never succeed if you do ERAS by your own. You have to imply all the stakeholders of your team. So once again, I go back to the recommendation we published in the Spine Journal. It's in open access. You can download it if you want. And we will have the summarization and the analysis of all the topics to help you to implement ERAS in your own institution and create your own ERAS. In conclusion, we have to reposition ourselves, not only the patient, because the patient changed, and patients of today are not the patient of when I was resident, but the caregivers, the institution, and the payer. And of course, it's multidisciplinary. Of course, it takes time, and energy and sacrifice to fight against our habits and to change the habits of all the people, and to try to have homogenic procedure for each step. But when you consider it, at the end, it's very rare that in surgery you have innovation with good results where all the parties are satisfied. The patient, of course, the physicians, anesthesiologists and surgeons, the caregivers, the director of your hospital, and even at the end, the payers, because you will spare some money at the end of the curve. So it was the first Coca-Cola in France in 70 years ago, and it's just to prove to you that it's not easy to change the habits of the old French guys. So I thank you for your attention. I think I'm finished with my long topics. I hope I didn't bother you.
Well, thank you, Bertrand, for this very comprehensive overview of this, as you say, holistic concept. I think that this is very interesting and will be playing an important role in the next years for every aspect of spine surgery, as the minimal invasive surgery has been, as it was invented. Well, initially a lot of discussion. So whoever has some questions, please use the chat box or the Q&A box. And I will read your questions, and then we can discuss those aspects or questions you have. Now, first, I have, when looking at the literature now, what we have on ERAS, there finally the major number you got to find is always length of stay, and you mentioned this is just a benefit you get of it, that it's not the core of it where it should lead to. And you mentioned that the different complications for hip replacement, for a colonic surgery, but is there already something for spine cases showing that complication rates are going down in certain cohorts of patients, and that the functional outcome remains the same? Do we have good larger case series or cohorts of patients where this is already shown?
It's too short. We have some very partial results, like in my paper that we published in the Neurosurgical Focus. We just analyzed the complication, and we demonstrated that there were significantly less postoperative hematoma. But and this kind of result you can find now. Maybe it will take more time to have convincing result in terms of complication. But at the end, I'm not sure that it will be very spectacular in spine surgery that you can have in hip or arthroplasty, because I try to once again, because I use a lot of time in a lot of PowerPoint my equation with the unknown factor, and spine surgery depends of factor we can't master, and I'm not sure that we have so spectacular result comparing with colonic surgery and hip arthroplasty. But
probably you should expect a difference in the medical complications, as talking about pulmonary thrombosis, cystitis, and the medical complication might be if the patient earlier out of bed and on his own feet.
What is the indirect result, convincing result now are the percentage of readmission at 1 month and at 3 months. It's in relation direct with the improvement of the procedure and the decrease of the complication. But and the important one, you see there is an history of the publication concerning new techniques. At the beginning, it was just RCP. You had the first clinical paper, then the first review, then the first guideline, and now maybe more structured clinical studies in a few years.
Okay, but so far, what is your, in which cases are you using an ERAS concept, and where would you think it's most useful? You had this you showed you one publication about ACDF's propensity matching. On the other hand, an ACDF is patient comes in, gets an ACDF, and is discharged.
Yeah.
On maybe 2 days later, what
yes,
on a regular
use,
basis. So you would expect that you have the majors or the biggest benefit in really big complex spine surgery when you think of any deformity cases, or I think the majority on publications now is on 1-2 level lumbar fusions.
Yeah, sure. That's that's why we choose. We were severely driven by the ERAS Society, but we dedicate the first recommendation to short fusion because it's the highest percentage of fusion worldwide. And I hope that another teams will do such work concerning anterior approach or cervical level, I don't know, or deformation. But in my institution, I changed from Toulouse to Paris, and in Paris there are no culture of ERAS, so I have to go back from the beginning. It's demanding, but in Toulouse, when I lived 2 years ago, they use ERAS for all the procedures, and of course it was not this at the beginning 10 years ago when we begin by the ambulatory, because we have the same organization for ambulatory ERAS, and because for me it's the same, and we began to dedicate ERAS to ambulatory lumbar discal herniation and cervical herniation, and then we go to short posterior fusion, and then it depends of the money that the hospital can give for the dedicated nurses, for example. But in my paper concerning the mobile application, we made a little medical economic study, and in France, it's difficult to compare between all the countries, even in Europe, but in France, for my institution, it was 50 euros to pay the application and the nurse per patient. So you can imagine that with 50 euros per patient, it's good because the turnover of the patient is increased, and it's a good operation for the institution. But now, when I left Toulouse 2 years ago, ERAS was for all the patients. That's why I say that in few years, ERAS will be just the rule, and there is no problem with ERAS. Yeah. And I have to say that we didn't use at this moment ERAS for the brain surgery, because in Toulouse I performed the 2 surgeries, but we saw, even if the brain patient was not integrated in the ERAS protocols, a decrease of the length of stay of the patient, change of the use of the surgeon in terms of drainage or navigation and so and so, and with more or less ERAS-like attitude with the brain, even if the brain patient was not integrated. So I know that there is a current work from the ERAS Society on the brain surgery. I hope there is already some very promising paper from different teams with ERAS and brain surgery, and I'm confident. But at the end, I think it's interesting for little surgeries like lumbar discal herniation, but very interesting for complex surgeries, of course.
Yeah. Okay, you already talked about some money. There's one question in the chat asking for reimbursement. What about reimbursement issues that we have in some countries? The problem that the reimbursement does depend on the length of stay.
Sure.
Well, this is different in all countries, but is there? Add another question: Is there already a negotiation with the health insurer that ERAS is different to the regular stay, and that you can give a code to ERAS and the patient is going to get adequately reimbursed irrespective of the length of stay?
Of course, it's a main problem, but it's always difficult to make a good answer to this question.
Yeah.
In a European discussion. I read the words of Enrico Tessitor, and we published with him 2 papers on ERAS with Marco Cognola, and it's a good friend, I know that I don't know in the panel of today, I think that in Austria, I am not sure, but in Austria or Portugal, there is even the surgeon can receive less money if the patient stay if the hospitalization is too short. So of course, it's an absolute barrier for the adoption of this technique in France 10 years ago. Yeah. It was the same for the lumbar disc herniation. There was thresholds, and this threshold were rare. And for years and years, the authorities, those surgeons are very conservative. They don't switch to ambulatory surgery for lumbar disc herniation. But of course, because for the institution, private and public, it was less reimbursement. So the director said, "Fuck you." And when this threshold disappeared, suddenly everybody switched to this, and because it's easy, because the patient is happy, and at the end, the patient were more happy than surgeon. But it's a question of money, and in Switzerland, I see the words of Enrico. Till this problem is not addressed, it will be a very important barrier to the length, to the obvious decrease of length of stay provided those techniques.
Okay.
And
there's one general question in the chat which asks for a thromboprophylaxis medication in spine surgery. What do you use? So
it depends of the we follow in France we follow the recommendation of the French Society of Anesthesiologists, but if the patient has no history of thromboembolic disease, we use for surgeries like lumbar disc herniation, of cervical disc herniation, of ALIF, no prophylaxis, or for short fusion, very short until the end of the hospitalization, and then left without nothing.
Yeah. Okay. So when someone is considering to adopt a ERAS concept, what would you recommend? Doing this stepwise, in just to do some major steps in the beginning, or just start with the whole concept, with the whole preoperative, intraoperative, and postoperative, with all aspects of ERAS? Would you make it a complete shift? What is your experience? How did you do it?
I think that it's interesting to select one procedure. For example, now cervical disc herniation, because I don't know, maybe I don't know it works in Germany, but in a lot of countries, lumbar disc herniation are already in ambulatory. So cervical disc herniation or something short, and but to take the whole concept, because afterwards it's difficult to go back to the re-implementation of new concept when all is done. And it's obvious that you will discover that you are already using ERAS-like attitudes in your institution, or it's but one of the most important and difficult parts, I said it a lot of time during this presentation, that it's to fight against the conservative attitudes of all the people, and not only the surgeon, but surgeon are very conservative, but the administration or the anesthesiologist, and to create an homogenic and standard attitude. I gave you the example of the drains, but it's good luck for the drains, and it's only a little step. But because you all know the literature concerning drainage of spine surgery. If you drain a patient, whatever the procedure today, you drain it for yourself and not for the patient.
Yeah, that's probably true.
That's written. So it's for me, I will prepare all before, and I will do all the whole procedure, but I will apply it to one selected procedure frequent in your institution, and then you will see that it's very easy to switch to another one, and even you begin that have this kind of result to the other patients, even if they are not officially integrated in the ERAS development in your institution. That's
okay.
Okay.
So we have no more questions in the chat. Bertrand, thank you. It was a very nice presentation, good discussion. I think a very nice, generally very nice webinar. So we're just announcement for the next ones. We'll have the next webinar beginning of May, and its presenter is going to be Enrico Tessitore from Geneva, Switzerland, who will give a presentation on craniocervical junction trauma, covering all aspects, diagnosing and management of craniocervical junction trauma. Then we'll have another webinar beginning of June, which is not completely clear about the topic. We're just in a discussion, and then we go in a bit of a summer break before we return in September. Thanks for this one, Bertrand. Very nice.
Bye.
And hope to see you soon. Thank you to everybody who joined us, and see you for the next time in the beginning of May. Thank you. Bye-bye.